So one of the abstracts that kind of rose to the top of the list is the Niche-3 study. So this was a study of using neoadjuvant nivolumab plus relatlimab, which is an anti-LAG-3 monoclonal antibody, in patients with locally advanced mismatch repair deficient colon cancers in a single-arm phase 2 study. And we know that the treatment paradigm for mismatch repair deficient, locally advanced rectal and now colon cancers has really shifted from a surgery followed by chemotherapy approach to really a neoadjuvant immunotherapy approach, sometimes followed by surgery, and maybe in the future, even omitting surgery. In this study, 59 patients got 2 doses of nivolumab with relatlimab prior to surgery, and most of these patients had pretty bulky right-sided primary tumors that were T4 and or node positive. Only about 19% of the patients had Lynch syndrome. And what they found was a very impressive pathologic response. So at the time of surgery, there was a pathologic response in 97% of the patients, including 92% who had a major pathological response, which means 10% or less viable tumor. 68% had a complete or total pathologic response with 0% viable tumor remaining. And out of all the patients, only one had disease recurrence, although the short-term follow-up of only 8 months, which means a 98% disease-free survival. And this was pretty well tolerated, except for, as to be expected, some immune-related adverse events, including 29% of folks who had infusion-related reactions, about a fifth of patients that had thyroid dysfunction and fatigue, but only 10% had a grade 3 or 4 immune-related adverse events. Of note, 24% had hypothyroidism and 8% had adrenal insufficiency, and they required long-term hormone supplementation. So my takeaway from this study is that this could be another neoadjuvant combination with immune therapy beyond the established combination of nivolumab with ipilimumab or PD-1 monotherapy. It was well tolerated except for some endocrinopathies, and that this may be a role in the future of non-operative strategies of not actually doing surgery and just doing IO. But currently the paradigm seems to be a couple doses of immune therapy followed by surgery for this rarer population, which is only about 15% or so of patients with locally advanced colon cancer. Another study to highlight is the CodeBreak 101 study. So this is studying patients with metastatic KRAS G12C mutated colorectal cancer in the frontline setting in a single-arm phase 1b study. In this study, they used sotorasib, which is a KRAS G12C inhibitor pill, with panitumumab, an anti-EGFR inhibitor, and using FOLFIRI as the chemotherapy backbone. And this was a smaller study, about 40 patients, but very impressive response rate. 75% of patients had a response. All were partial responses. 17.5% of patients had stable disease, and a very impressive disease control rate of 92.5%, and a quick time to response of only 1.5 months. This was fairly well tolerated, although there were about half of patients who had grade 3-4 treatment-related adverse events, notably neutropenia, rash, and diarrhea, no grade 5 events. And about 2/3 of the responders were still on study with an ongoing response, again, with a short-term follow-up, a median of only 6.7 months. My takeaway from this study is, there's a tolerable combination of targeted therapy and chemotherapy in the first-line setting. It's hard to find these patients. It's only about 3 to 4% of patients with metastatic colorectal cancer that have a KRAS G12C mutation, so it requires early tumor sequencing, next-generation sequencing to find these patients prior to starting therapy. But it does build off of promising data we've seen in later line settings. The CodeBreak 301 study is an ongoing phase 3 trial, which just started, of comparing this combination with the standard of care FOLFIRI with or without bevacizumab, with the primary endpoint being progression-free survival. Another study that was updated at ESMO 2024 was the Keynote 811 study. This is a study in patients with unresectable metastatic HER2-positive gastric or gastroesophageal junction cancer using pembrolizumab with trastuzumab chemotherapy. In this case, it could be either 5-FU cisplatin or CAPOX versus placebo with trastuzumab chemotherapy. We already knew that this study was positive, looking at PFS and overall response rate. This was a study of almost 700 patients, and we now finally have the overall survival follow-up, which showed an overall survival of 20 months versus 16.8 months on the placebo arm with a hazard ratio of 0.8. This was slightly more impressive if you included patients that had some degree of PD-L1 positivity, a CPS score of 1 or greater. The survival was 20.1 versus 15.7 months with a similar hazard ratio. Response rate also higher, as stated previously, 72.6 versus 60.1% with no new safety concerns. So this is a regimen we've already become comfortable with and is already really the standard of care, but this further supports and builds on, again, this earlier data that showed progression-free survival response rate benefits. It's already FDA approved for patients with a PD-L1 CPS score of 1 or greater. In this study, only 15%, 104 patients, had a CPS score of below 1, and their overall survival was inferior with the addition of pembrolizumab, 18.2 versus 20.4 months, with a hazard ratio of 1.1. So it does, again, support not giving pembrolizumab with chemo trastuzumab in patients with really no PD-L1 expression. But for those who have any PD-L1 expression of 1 or greater, this is really still the standard of care. Another interesting HER2 positive gastroesophageal junction esophageal adenocarcinoma study was looking at the antibody drug conjugate trastuzumab deruxtecan in the DESTINY-Gastric03 study, in which patients were randomized to either standard of care, which was platinum fluoropyrimidine doublet with trastuzumab, and then different combinations of either trastuzumab deruxtecan monotherapy at the 6.4 mg per kg dosing, or in combination with 5-FU or capecitabine and or pembrolizumab. And patients were stratified by either HER2 3+ or 2+ with ISH positive. And they were enrolled regardless of whether they were PD-L1 CPS positive or not. 229 patients were treated. The monotherapy response rate in the frontline setting was 49% with just trastuzumab deruxtecan alone, which is impressive, a 9-month progression-free survival and 18-month overall survival. There were some high response rates when combining trastuzumab deruxtecan with 5-FU. It was up to 78%, again, regardless of PD-L1 status. And there were also high response rates in some of the pembro combinations. Of note, their interstitial lung disease, which is a very important safety issue with trastuzumab deruxtecan, was found or determined to be found in 11% of patients, including 3 patients who died from interstitial lung disease. Of note, 51% of patients discontinued treatment due to adverse events when they were on the triplet combination arm of trastuzumab deruxtecan, 5-FU, and pembro. As such, they're exploring the lower dose of trastuzumab deruxtecan, which I find to be more relevant, and there's a lot of data to support this to be safe and just as effective in clinical practice, of using the 5.4 mg per kg dose instead of the 6.4 mg per kg dose. And they'll be looking at that again in combination with 5-FU and pembrolizumab. So we await kind of the results of larger studies evaluating that combination, especially at the lower dose, which is probably more tolerable. Another important gastric study to highlight that was presented at ESMO 2024 was the Top Gear study, which has a great name. This was in patients with resectable gastric or GE junction tumors that were Seward type 2 or 3. These were locally advanced bulky tumors that were either T3, T4, and or node positive. And in a large phase 3 study, they basically looked at perioperative chemotherapy versus chemo, followed by chemoradiation with 5-FU in the neoadjuvant setting, followed by surgery, followed by adjuvant chemo. And in this case, the chemo was either ECF or FLOT. About a third of patients received FLOT. And it was a large study of 574 patients. Of note, there was a higher pathologic complete response rate on the chemoradiation arm, 16.8 versus 8%. But everything else was completely awash. The median overall survival was the same, 46.4 versus 49.4 months. 3-year overall survival, 5-year overall survival was essentially the same statistically, not significantly different. So this is yet another study that shows that adding pre-op chemo-RT improves path CR rate, improves downstaging, but ultimately has no effect on survival. So kind of another study showing kind of a lack of benefit of using radiation in resectable gastric cancer. The Moonlight study was another interesting gastric study that was presented at ESMO 2024. This was a study in the first-line setting for HER2-negative metastatic esophagogastric adenocarcinoma of FOLFOX versus FOLFOX given with doublet immune therapy, nivolumab, ipilimumab, either in parallel or with FOLFOX or sequential following FOLFOX. And there was also an arm that was given FLOT, kind of a spicier chemotherapy regimen with nivolumab. So there were 262 patients enrolled. It was quite a complicated, confusing design due to amendments and how patients were randomized and allocated to these different arms. But in all, the arm that got nivolumab with ipilimumab and FOLFOX was associated with sort of increased toxicity and maybe no better efficacy. Interestingly, the FLOT nivolumab arm, which we kind of worried more about toxicity, kind of had the best efficacy of the group with a response rate of 56% and a median overall survival of 14.6 months. But again, with small numbers in each cohort, it's very hard to interpret beyond that. What they did sort of show is that we should not be giving chemo followed by IO and sort of a sequential or maintenance strategy did not seem to work. So if you're going to give IO, we should really be giving it concurrently or in parallel with chemotherapy, and which makes sense because the benefit from IO is small and there really needs to be a long lead time to benefit. So if we're going to give IO, this further supports giving it up front in combination with chemotherapy. And then the other interesting finding is that there may be a role for FLOT with nivolumab, which is kind of a new regimen that hasn't been tested much, but this should be evaluated in larger trials for fit patients. Moving on to hepatocellular carcinoma, there was the presentation of the LEAP-012 study. This was a phase 3 trial looking at adding lenvatinib and pembrolizumab with TACE versus placebo with TACE in intermediate stage hepatocellular carcinoma. So these patients were Child-Pugh A, no portal vein invasion, not amenable to curative treatment. Patients were given lenvatinib either at the higher dose, 12 milligrams if patients were 60 kilos or more in weight, or 8 milligrams daily if they were less than 60 kilos. And for the TACE, they were allowed a maximum 2 treatments per tumor or 4 total. 480 patients were randomized. The primary endpoint was progression-free survival, which was improved with the addition of pembrolizumab lenvatinib, 14.6 versus 10 months with a hazard ratio of 0.66. The overall survival, not yet mature, hazard ratio of 0.8, but the significance threshold has not yet been met. But interestingly, the 2-year overall survival so far, landmark 74.6 versus 68.6%, so a small, at least numerical increase in 2-year survival. There were more grade 3 to 5 treatment-related adverse events, 71.3 versus 31.5%, but discontinuation of both drugs due to adverse events on the pembro lenvatinib or placebo was rare. It was only 8.4 versus 1.2%. So we need kind of the overall survival data for this to really confirm these findings. But again, there may be a role for incorporating treatment that we've been using in patients with advanced HCC and moving it into sort of the intermediate disease state in combination with local therapy, in this case, TACE. Another HCC study that was updated at ESMO 2024 was the Himalaya study. This was a large clinical trial, phase 3, where patients with unresectable HCC of using the STRIDE regimen, durvalumab and tremelimumab, so combination PD-1 CTLA-4 blockade versus the old standard of care in this case, which was sorafenib. 5-year overall survival data further supported that this regimen is superior to sorafenib with a hazard ratio of 0.76 and an absolute 5-year OS of 19.6% versus 9.4%, with no additional safety signals. So my takeaway from this study is that there really is a new overall survival benchmark. 20% of patients being alive 5 years out with HCC, advanced unresectable, treated with immune therapy is quite an accomplishment that we shouldn't forget about. And again, because our old standard of care, sorafenib, is clearly inferior. So this really represents and supports that, in HCC, we've moved quite further down the road into the immunotherapy space quite successfully. The POLAR study was presented at ESMO 2024. This is an interesting phase 2 study of pembrolizumab and olaparib maintenance for patients with metastatic pancreas cancer in sort of 3 groups. So one group was homologous recombination repair deficient. They had germline BRCA1 or 2 or PALB2 mutations and had to be on platinum chemo for at least 4 months. A second group that had non-core HRD mutations. In this study, those turned out to be patients with ATM, CHEK2, MUTYH, BLM, and FANCC mutations who were also on platinum for at least 4 months. And then finally, there was a third group who were just exceptional responders to platinum chemo without an HRD mutation. They had to be on platinum chemo for at least 6 months. In all, 63 patients were enrolled, 6 of whom remain on study for more than a year and a half later. Of the HRD group, there were 33 patients with a 35% response rate to pembro, olaparib, PARP inhibition with PD-1 blockade, and that's quite impressive with a 90% disease control rate at 6 months, and their median overall survival has not yet been met. In the second group, there were 15 patients who had these non-core HRD mutations. Their response rate was not as impressive, it was only 8% with about 50% disease control rate at 6 months, median overall survival of 18 months. And finally, in the 15 platinum responders, non-HRD, their response rate was a little higher, 13.5%, with a 20% disease control rate at 6 months, but a short median overall survival of only 10 months. So they try to kind of, study all these patients together, but they appropriately lump them separately because, as you can see, they're quite different populations. But clearly, there does seem to be some potential benefit of a maintenance anti-PD-1 plus PARP inhibition strategy, especially for these patients with germline HRD mutations and have a response or benefit to platinum, building off of the POLO data that show that maintenance olaparib has some degree of benefit in patients with platinum-based chemo responsiveness and germline HRD mutations. And finally, the CABINET study, which we participated in, was a large phase 3 study looking at patients with either progressive extrapancreatic neuroendocrine tumor, in this case, mostly GI extrapancreatic, or pancreatic neuroendocrine tumors. And patients had to receive either prior PRRT or targeted therapy or both. And they were randomized 2-to-1 to receive cabozantinib, an oral TKI, at 60 milligrams daily or placebo. And the primary endpoint was progression-free survival by blinded central review. This was a heavily pre-treated population. 60% had prior PRRT, 90+% had had prior somatostatin analog, and the patients had a median of 2 prior lines of systemic therapy, not counting somatostatin analog. 203 patients, overall median progression-free survival was 8.4 versus 3.9 months with placebo, with an extremely impressive hazard ratio of 0.38. Even more impressive in the pancreatic neuroendocrine tumor group that was analyzed separately, 13.8 versus 4.4 months of progression-free survival compared to placebo. That was a hazard ratio of 0.23. Response rates were low, only 5% in extrapancreatic NET versus 19% for cabozantinib in pancreatic NET. And there were more grade 3 and higher adverse events, about 2/3 of patients, including hypertension, fatigue, diarrhea, and thromboembolic events. So again, this is a heavily pretreated population of patients who've had basically the standard therapies for extrapancreatic and pancreatic neuroendocrine tumors. So cabozantinib seems to be a viable treatment option in patients with refractory neuroendocrine tumors. So definitely moving the field forward, and something that I would definitely think about in our heavily pretreated pancreatic neuroendocrine tumor and extrapancreatic neuroendocrine tumor patients.